We can all recall a shift where we went home feeling like the patients we were allocated did not get the care that they needed or deserved, because there was simply too much to do in the shift that we had and not enough of us to go around. It was once thought that technology and system support would ease a nurse's and midwife's workload. But this isn't the case. It's yet another layer of complexity added to the work that we do every day. The health system is indeed under pressure. The challenges are many. But there is one thing that never changes. There is a patient at the centre of everything we do, who needs nursing care to help heal them, to rehabilitate them, to teach, to care, to deliver, but above all, to keep them safe. Today we join together to listen to some preeminent nurse leaders and researchers, some industry professionals and experts who will share with us their learnings about the connection between nurses and midwives and patient safety. I'd like to welcome to the podium now Beth Moll, the Secretary of the Queensland Nurses Union.
Thank you, Sally. Firstly, I'd like to acknowledge the traditional owners in the land on which we meet, the Yagara Nation, who are from south of the Brisbane River, and the Turrbal Nation from north of the Brisbane River, and pay my respects to their elders past and present. A special thank you to Uncle Bob for his wonderful welcome to country. Uncle Bob is a long-standing and valued friend of the QNU, and he always does welcome to countries for our events, so it's always terrific to have him here. It is my pleasure to formally welcome you all here today for this very important symposium on the theme of keeping patients safe. In the context of the agenda of austerity measures being pursued by governments and private health and aged care providers in Australia and around the world, this topic has particular resonance for nurses and midwives and those that we care for. As we know from surveying and talking to members across all sectors, their number one concern at present is their capacity to provide high-quality nursing and midwifery. This was the dominant theme to emerge from the QNU's Your Work, Your Time, Your Life survey that was conducted in 2013. It's also been repeatedly reinforced in the telephone calling we've been doing to ascertain the key issues of concern for members in the lead-up to the next Queensland state election. Members are concerned that no matter where they work, the budget rules supreme, and this all too often results in a short-term efficiency agenda that sees nursing and midwifery and skill mix cut. This occurs despite the consistent and irrefutable international evidence that demonstrates the central contribution we make to the delivery of safe patient care. Our members are concerned that the short-term focus on budget integrity, or the dollar bottom line, seems to invariably trump safety and quality. There is a constant push to do more with less, and it's a never-ending struggle to have the true value of our contribution to the delivery of effective, safe patient care recognised and acknowledged through action. This is a source of significant ethical distress. One nurse from a private hospital survey succinctly summed it up as follows. Driven by profit, it stands to reason that they will always attempt to reduce costs, and this often equates to reduced quality of nursing care. I feel that as each year passes, more is expected of nursing staff, and I now work harder than ever before. Today's symposium has been organised so we can place the spotlight on the vital contribution we make individually and collectively, day in, day out, to keeping patients safe. There are so many elements to ensuring patient safety, and this symposium covers a number of them. The evidence, be this international, national or local, the workplace context, the need for leadership and operating in a manner that is consistent with our values, the community's needs and expectations, and the regulatory context. We are so privileged to have with us in Queensland our keynote speaker, the internationally renowned nurse researcher, Professor Linda Aiken from University of Pennsylvania. Queensland's Chief Nurse, Dr. Frances Hughes, will introduce Professor Aiken in a moment. We also have nationally renowned nurse researchers, Professor Jill White and Professor Wendy Chaboya, who will provide key insights into the Australian evidence. This will be followed with the presentation on local nurse-sensitive indicator research by Veronica Casey and Sandra Moss. After lunch, Professor John Buchanan from University of Sydney will elaborate on the contribution that the workplace environment and culture make to maintaining patient safety. Then Q-Super CEO and the 2013 Telstra Businesswoman of the Year, Rosemary Viljoen, will provide a perspective from a sector other than health on the vital importance of values-driven leadership. Melissa Fox will follow on from Rosemary and provide the crucial perspective of those we care for. The symposium will then close with presentations from Queensland's Health Ombudsman, Mr Leon Atkinson McEwen, and the Mental Health Commissioner, Dr Leslie van Schuenbreck, who will outline their roles in ensuring patient safety. So you can see we have an excellent lineup of speakers today. The objective is to arm you with evidence and inspire you all to continue to take action to keep patients safe, both as individual practitioners and collectively through organisations like the QNU. Our members are our union, and we know that ensuring patient safety and the delivery of high-quality care is their number one priority. This is also consistently the top priority for our community. The QNU is embarking on a significant long-term campaign to promote high-quality care through effective nursing and midwifery workload management and ensuring the true valuing of the contribution of our members make 24/7 to patient safety. Central to the success of this campaign will be our capacity to confidently and consistently articulate our case to politicians, decision makers, the media and the broader community. It is a simple message. We keep our health system both safe and human. If we do not step up to the challenge and get this essential message through, then who will? Nurses and midwives care for Queenslanders from birth to death. We are the constant presence for those who are sick. We are the voice of those when they are at their most vulnerable. We are focused on keeping people well and out of hospital. The safety and quality of the care we provide to our community is at the heart of everything we do. We work collectively through our union, the Queensland Nurses Union, because we are a powerful force when we act together. Our values are mutually reinforcing and guide everything we do. Our nursing and midwifery values of caring, advocacy, holism and professionalism drive us. Our union values of fairness, collectivism, equality and opportunity unite us. We must place these values at the heart of all we do and make politicians and decision makers responsive to our values and our priorities. So welcome to this important symposium. Thank you for your attendance. Let this be the start of an ongoing, intensified collective effort to reframe the debate and reorder the priorities. The provision of high-quality, patient-centred, universal health care, where access to care is based on need and not capacity to pay, is the hallmark of a fair society. We all have an important role to play in maintaining this objective, and this starts with recognising and prioritising our vital role as advocates for high-quality health care for all. Thank you. Now, I would just like to introduce Dr. Frances Hughes, the Chief Nurse of Queensland. We have worked very closely with Frances and her office to bring together this symposium, and it's been a fantastic collaborative effort. Frances will introduce Professor Aiken this morning, so I'd just like to put on record my thanks to Frances and her office for all of the hard work that they've put together for this event. Thanks.
Thank you, Beth. And I also would like to acknowledge that there was a group of, when we had an idea about actually looking at evidence and thinking about putting patients in the middle of everything we do, it didn't take me long to realise that I needed to call on some of my international colleagues and networks to help us to frame up what is actually occurring around the world in regard to patient safety. And so Linda is someone who took the call, and I think that sums up a lot about this wonderful person that you have in front of you. But I also want to acknowledge that, yes, that my office and my staff in my office have worked incredibly hard to bring about this whole week of having Linda in the state, and she's only coming to Queensland and only coming to Brisbane and to Cairns. But I just want to acknowledge that, you know, we had a small working group, QNU, wonderful, stunning partner to work with Beth. We had Anita Bamford from Gold Coast. We had Linda from Cairns. We had James Cook University. We had Julie from Mackay. So we had a group of EDONs and other significant people who, when you run a committee, you always know who's the one who can bake more cakes, you know, and you call on these people. So we've managed to do a lot of logistics around supporting Linda and Jill and John to get them all here today. How do I describe Linda? Well, I first came to know Linda as a person, apart from being one of those people that you've read about as you go on your own journey of education, really in 2000, when I was awarded a Harkness Fellowship in Healthcare Policy to study in the US. And my mentor in the school that I was to go to was University of Pennsylvania. And it was a centre, it was Linda's centre. So I met Linda, and then I arrived in the country. I arrived on the 8th of September 2011. 2001, I should say, 2001. And Linda was, as my mentor, I was based in New York for that week at the Commonwealth Fund in New York. And Linda was to come as my mentor with the other 5 overseas there was UK, Australia, New Zealand, Canada. All of us had been selected from our countries to this very prestigious award, and Linda was coming into the New York to be with me for my orientation. And of course, 9 o'clock on the 9th of September 2001, the world changed. And so I got to know Linda in a very different way. I got to know her as the rescuer who got me out of New York, who supported myself and my family when they eventually would come over, because they were meant to be over. She became my flatmate. She put me up in her home. And it just epitomised the depth of this woman. She has, and I've counted this up, she has received 53 national and international awards in the last 23 years. She has received 5 honorary doctorates. Linda's research on nursing quality and safety and patient care has had far-reaching effects, and you'll hear about that in her presentation. But I think there's 2 things for me that have always resonated. One is her research has always been about what it means and what's occurring with patients. It has always been around nursing, and it has always been about how to influence health policy and decision-making in states and countries. And as her work's got bigger and bigger, and it's now in 30 countries, and we are trying to do some work in Australia as well now, it has a profound influential effect on decision-making. The issue around how the focus of her work is about public's awareness of nurses' importance, working conditions, and the fact that her empirical and scientist within her has managed to do this and do it and absolutely keep absolutely valued and absolutely kept in the nursing context has been profound. She would be the only nurse scientist who's managed to do this in these countries with these massive big data sets. So for me, what her work does, it blows away many of the assumptions. It challenges often the myths that we know. As her research is coming out, it's challenging our views on casual workforce. It's challenging the works on the registered nurse versus other workforce. It challenges the need for why our managers must take notice. And of course, this has been epitomised in these various awards, as I've said she's had. And there's 2 that stand out for me. One is top 100 influential health, people in health in the US. And the other was one that she just received this October, which is the Lionheart Award. And the Lionheart Award is the outstanding national achievement in improving personal health care in the United States. There's only been 29 others who have ever got this award. It's like the Nobel Peace Prize for me of health care. And it has actually taken not only nursing into a different frame, but actually has allowed other people to actually acknowledge that we aren't just a big group and we're not just going to go away. So for me, she's been a privileged colleague, and I've formed a wonderful friendship. She is someone who is always there when you need to call on, when you get challenged, as we do every day, like you do, about why nurses need to do this and why do we need nurses, and you cannot ignore the research and influence that she's had. And I just hope that you live for many years, Linda, because, or you have a lot of protégés under you, because it's the level that you're functioning at will need you for a while to come. Thank you very much. Welcome.
Thank you very much. I'm going to try to use my rock star things here, so if you can't hear me, please let me know. So I think, Frances, you've been here for 2 years or something, right? 2.5 years. So you probably realize that Frances is, of course, with me, and I've really had the privilege of working with Frances on my international research agenda when she was in New Zealand, now here, which is wonderful. And what I'm going to be talking about today, the impact of nursing on patient outcomes, is really a product of the work of about 30 fabulous collaborators like Frances all over the world, which shows really the tremendous power of the global nursing network. Now, I'm very happy to be here in Brisbane. I live in Philadelphia, and it's full of snow, but I'm from Florida. And so I feel right at home here because it feels like Florida. And the first new person I met here was Beth, who took me on a wonderful trip on Sunday and has been a very nice host and had a chance to meet with other leaders in the organization. And then my first formal event, which was very exciting for me, was to be at the Princess Alexandra Hospital when they were redesignated. And Veronica Casey is here, and let's just give them a brief applause, because it's really a wonderful accomplishment. So today I'm going to give you kind of a broad brushstroke of some of the findings that we're getting from studies of 30 countries around the world. And I should say at the beginning, Frances, I know you can do this, because if I have this coughing fit, because I'm kind of fighting off with my zinc lozenge or some little tickle in my throat, Frances will start in my mid-sentence and keep going right while I recover if I have a coughing fit. Okay, so don't get upset, I'll recover, but Frances will take over. Most of the data that I'm going to be talking about today, hopefully in not too boring a researchy way, I'm going to talk about it from the 34,000 feet level to try to share what our main findings are. Most of the information, even though we studied 30 countries in most parts of the world, will come from Europe and the U.S., which seem to be the countries that are probably most comparable to Australia. We've also, in addition to working in Europe, been in a number of countries in Asia. We just finished a national study of nursing and patient outcomes in China, the first large study of its kind ever done in China. We've also worked in Thailand, South Korea, Japan, so pretty much covered the Asian region. We have a national study of South Africa. Number of other, New Zealand obviously was in our original study, along with Canada, some countries in Europe, which we've now updated, and at the moment we're working in Israel and Chile. So we've been kind of everywhere in the world, and the reason why we've been interested in studying these issues is because we thought that the generic relationships between what nurses do and patient outcomes were probably the same everywhere, and that if indeed they were the same, then we could share many of our innovations and not recreate the wheel all the time, which we are prone to do. And also our policymakers are prone to say, if you didn't do the research here, it doesn't apply. And so I'm hoping, and having a little luck with this, to convince policymakers across the world we've done this in 30 countries all over the world. And even if we haven't been in your specific country yet, that seems to be a big enough variation to show that these are generic issues in healthcare that apply everywhere. And so if any of us has a good solution to solve some of these challenges in healthcare, it will probably work in any of our other countries. And the magnet is a good example. I was there at the birth of Magnet, which started out to be a U.S. idea, and now it's in Australia and other parts of the world. So that is kind of the lay of the land. Very briefly, what we've done in Europe is we have done the largest study that's ever been done of nursing and patient outcomes in Europe. Involved 12 countries, which you can see on the map here. We sampled hospitals in all these 12 countries in a stratified way so that they represented all hospitals of over 100 beds in the 12 countries we studied in Europe, which are countries from the west, the south, and the east, so representing pretty much the European Union. We studied 617 hospitals, over 2,000 nursing units. We surveyed 34,000 nurses who worked with patients. These are direct care nurses at the bedside. We surveyed over 11,000 patients to obtain their own direct view of their satisfaction, not only with nursing care, but their satisfaction overall with hospital care. And then, and this is the key to what we do and what has made, I think, our results very powerful, is then we take patient-independent actual patient outcomes and we link them to these hospitals and these nurses so that we know from independent sources what the outcomes for the patients cared for by those nurses. And so we've also done the same thing in the U.S. We've now created a big panel of about 800 hospitals we've studied twice and are now getting ready to go into the field. Francis was telling me, I think there are 250,000 nurses in Australia, right? Something like that. In Queensland? Well, something like that. So 1st of January, we're getting ready to survey 350,000 nurses in the U.S. from 4 states, where we'll be able to study the outcomes of patients in whatever organizations they work in, be they hospitals, nursing homes, home care, or whatever. So the data I'm going to be talking about today come basically from the studies that we've done in Europe and the U.S., but I could show you the same findings from the other countries as well. So first place we start is we ask nurses, thousands of them in different countries, are there enough staff in your setting to provide care of reasonable quality? And as you can see from my slide here, pretty much in every country, over half and more likely up to 3/4 of nurses say, no, there are not enough staff there to provide high quality of care. Across differently organized and financed countries, some countries with more resources than others, this is the standard reply that you get back surveying hundreds of thousands of nurses everywhere. And so what are some of the consequences of that that might make us believe what they're saying? We look specifically from all of these hundreds of thousands of nurses that we're studying in their settings, and whereas we're using nurses as informants of what goes on in healthcare, we're really studying the performance of their organizations. So we're using nurses to tell us a lot about the quality and safety of care in their organization, and then we're looking at various aspects of the nurse workforce and how it relates to patient outcomes. So one of the things that we thought we'd have to take a look at, if nurses say there are not enough staff at the bedside, well, why would that necessarily create a problem in patient care? So sort of an interim step that we asked the nurses was, of the needed nursing care on your last shift or your last day you worked, what things that were needed were you not able to get to because you didn't have enough time? And so what you can see here are some of our results from multiple countries. Again, these are countries differently organized, financed, and resourced, where a substantial proportion of nurses say they don't get to a whole series of needed things. Now, more nurses get to things like medication delivery and procedures, but look, for example, at these high rates of nurses that are not able to get to educating patients or comforting and talking to patients or preparing patients for discharge. So what does this particular thing have to do with anything? Well, one important thing that it has to do with something right off the bat is patients are not all that satisfied in our hospitals in any of our countries. Now, this is a little bit the issue of, is the glass half empty or half full? Normally, I'm an optimistic person, and I say I go for the glass half full, you know, as an optimistic look. But I think when we look at patient satisfaction, which, by the way, all of our countries have adopted, along with the WHO, the idea that our citizens have the basic right to be satisfied with the health care that they are able to obtain in our countries. And so, therefore, patient satisfaction is a major indicator of quality. And as you can see across all these countries, when we interviewed patients, there is a tremendous room for improvement in patient satisfaction. In every single country, at least a third to 40% or more patients don't give their hospitals a top rating and would not recommend their hospitals to a family member or a friend who needed care. Well, if you look at that in the context of other businesses, I'd be willing to bet that the auto manufacturers here in Australia would have trouble selling their cars if 40% of all the people that bought one of their cars was not satisfied. So this is significant. And it's also significant when we look at the kinds of things that nurses don't get to because there are not enough people there. That is, all the interaction issues with patients. Now, patients may not be able to fully appreciate if you have paid attention to all the details of a procedure, if they've gotten their medicines on time, but they can totally appreciate if they've gotten any discharge instructions. So now that all of our countries are very concerned about trying to reduce hospital readmissions, trying to reduce length of stay, keeping people out of the hospitals in general, we see right here in this issue of care left undone a big explanation for why, even though nurses may be very good at doing some of the major procedures and medications, and we'll see later that this is not because nurses are not working very hard, they're working tremendously hard, and nurses have one of the highest job-related burnouts of any occupation. They're just simply not able to get to all these things, and so they are implicitly rationing care. Now, rationing is, you know, one of those things that we don't like to talk about in public, but I think this slide basically shows that nurses everywhere we've been studying them are having to ration care implicitly because they can't get to everything that needs to be done. So we could imagine that this not only affects patient satisfaction, but it could and does affect a lot of other outcomes for patients. So I want to pause for a minute. And by the way, we're going to have time for discussion. So we have microphones up there. So I hope you make a little note of questions or comments that you want to make as we go through this. So I want to first take up the issue of why there are not enough nurses. This is a confusing issue. It may not be confusing to those of you in the room, but I can tell you that it's very confusing to policymakers and people that are not nurses, because everyone besides nurses who have a better idea of what's going on believes there's a nurse shortage in their country. The general public think there are not enough people who want to be nurses. And so the quality issues that they confront when they're a patient have to do with some lack of nurses in the country. Well, that is simply not true. None of our countries, I don't think I need to tell you this because you know this well in Australia. The good news is you have a lot of nurses and you could do something innovative with that. But it's really not true that there's a nursing shortage. And so if we allow our problems of the lack of nursing care to be defined as a nurse shortage, then we won't get to the right solution because we don't have a shortage of nurses that can be solved by educating more nurses. We know now that the shortage of nursing is a shortage of care at the bedside and in all the clinical settings. And this has nothing to do and is totally independent of the national supply of nursing. So this is, important for us to explain to the public, important for us to explain to our policymakers, because solving the shortage of nursing care requires a different intervention than solving some workforce shortage. And ultimately, what we find in all the countries, and this is why so many nurses say there are not enough people to take care of patients, is that there are not enough budgeted positions for nurses and other caregivers. It's just plain and simple. It's all a matter of how much money and how we're spending the money that we have. So you will not be able to solve your shortage of care at the bedside if you produce 100,000 more nurses, because your problem here is that there are not enough positions that are funded to provide, from the point of view of the patient, enough nursing care. Now, hospital managers say to me all the time, we keep adding nurses. Is this just an issue that nurses are never going to be satisfied, that we're never going to be able to meet their expectations and have enough nurses at the bedside so that they will say that they're an adequate number? Well, the answer to that is kind of twofold. One is, it's true in most countries that policymakers and managers, except kind of recently when we've had austerity spending and economic downturns in some countries, in general we have been adding, over 10 or 20 years, more nurses at the bedside. But the problem is, because of health reform, austerity spending, which is reducing hospital budgets, resulting in a reduction in length of stay in hospitals, deflecting discretionary admissions to ambulatory care. And policymakers assume that if we reduce the number of inpatient days in hospitals, we could also reduce the number of nurses. But we can't, right? Because all the patients are sicker that are left in the beds. So in the U.S., over the last 2 decades, we took 20 million to 50 million inpatient days out of our system, but we have to have more nurses because every single patient in every single bed needs a lot of attention because we've reduced the length of stay so severely. So when I think about it in a way that I think is a way to explain this to your managers, everybody knows about inflation, and we are all monitoring inflation. And we look to see every year, is our salary keeping up with inflation, and preferably even outpacing it a little bit, so we really have more money in real terms to spend. But we all know that, for the most part, our salaries are not keeping up with inflation. So in real terms, we have less money to spend, and that is exactly the problem going on in nurse staffing. If we do an acuity adjustment or a complexity adjustment on the patient population in our hospitals as the equivalent of an inflation adjuster, there's not as much real nursing care there now, even though we have more nurses at the bedside, as there was 20 years ago when the patients weren't all so sick. So I think this idea of inflation-adjusted salaries, complexity-adjusted staffing is a general concept that we have to do a better job of describing. So what are the consequences of not having enough nurses at the hospital bedside? Well, one is poor clinical outcomes for patients. I'm going to give you some specific data on this, but briefly, when we don't have enough nurses at the bedside, we have higher mortality, more complications, lower patient satisfaction. And specifically, and of great concern, I've met a number of people since I got here that work with aged care. And although we tend to talk about unnecessary hospital admissions and potentially preventable hospital readmissions in economic terms because they're costing our country a lot of money, really there is a huge risk here that we're not we know, but other people are not focusing on, which is every time a frail elderly person goes to a hospital, it increases their odds of never being able to go home again. You know, that is really a frightening thing. And of course, if you talk to elderly people, what they want to do is they want to live in the community, preferably in their homes, as long as they possibly can. So often we're throwing around these ideas and talking about the effect on budgets, but things that are affecting budgets also have a very high human toll as well. So we ought to, as nurses, not only charge into the debate on the cost side, but always mention the human toll of unnecessary hospital admissions. So in general, we found across all the countries we studied that there's lots of room for improvement in quality and safety of care. If we look at the immense amount of attention that all of our countries have paid to try to reduce patient safety problems and medical errors in hospitals, most of the big studies have suggested that, given the fact that we've been working on it, throwing lots and lots of money at it for coming on to 15 years now, we have made very little progress. And one area that I'm particularly interested in, because we study surgery a lot, is in the U.S. it's been estimated that over the 15 years since the Institute of Medicine estimated that medical error was among the 5 leading causes of death in the U.S., we have made no progress making surgery safer. None. Which is astounding, given all this infrastructure of quality officers and everything we're doing in quality. So why is that? And what our research suggests is we have been ignoring a fundamental reality that has to do with quality and safety, and that is that nursing is foundational to quality and safety. And if nursing is not as strong as it needs to be, then this whole overlay that we're using of quality and safety is really not going to have its intended effect, because all of this depends upon the foundation of nursing. The ability of nurses to conduct surveillance, to recognize problems. They're the professionals that in every setting with the most contact with patients. There are not enough of them. If they don't have the right preparation, and if they're working in environments that are making them inefficient, then that is undermining all the other things that we're trying to do in safety. So the basic thesis of our work, which I think we've accumulated a huge amount of evidence, is the reason why we're not making more progress in reducing medical errors and improving quality is because we are not paying enough attention in nursing. As a matter of fact, nursing is a soft target for budget reductions. We always reach down there, and yet that is the foundation that without which we really can't guarantee quality and safety. So we have been about trying to educate the public in different countries and educating ourselves about what's really going on in healthcare, because there's often not a lot of transparency in variation across hospitals within countries, or even variation in staffing. So what we found, which is a little shocking in Europe, in our in the 9 countries for whom we could collect mortality data, that there's a 7-fold difference in mortality following common surgical procedures across these 9 countries in Europe. Again, differently organized and financed countries. Thankfully, the mortality rate for general surgery overall is low because people don't have general surgery if they can help it, if they don't expect to live and physicians don't recommend it. So the overall mortality rate is less than 1.5%. But as you can see from these figures, and what I've arrayed here on this chart is the mortality rate for every hospital that we studied in Europe. And every little line here is a hospital. And so some hospitals had no deaths from general surgery over the period of 2 years that we studied them, which is fabulous. But some hospitals had as high as over a 7% mortality rate. Now, these are all risk-adjusted, which means we took into account that different hospitals have patients that are differentially ill and so are at a higher risk of mortality. But I personally was kind of shocked by this, and the public, when you present it to them through the media, is very shocked to know that every hospital in their community is not the same. But what our research is showing is that it's not the same. So across Europe, you have a 7-fold difference in the odds of mortality depending on where you go. And this is the case even in the U.S. We have even a wider range of mortality in our hospitals. We have a 12-fold difference in mortality after general surgery. And I think I have the England results here because England has a National Health Service, which Americans always hold on a pedestal because we always thought that what England has is what we wanted, which is a standardized, reasonable level of quality accessible to every single citizen. So we did the study in England, and lo and behold, the green lines on this are mortality rates of individual NHS hospitals in England in a National Health Service. That is not a standardized product. So depending upon where you live in England, under the National Health Service, you have, again, about a 7-fold difference of dying after common surgical procedures. You can see the entire array of all the mortality across all the hospitals that we studied in Europe. And one thing that's important here, when we do this international work, and the press loves international work, so they always ask us, the first thing they say is, well, do we do better in England than Norway does? Or, what's the comparison between mortality in the U.S. and England? Well, that's not really the question. The question is, why do we all have so much variation in mortality in our own countries? Because we don't really think in terms of our hospitals providing such a different product. So basically what's so, I think, important about what we're finding is in every single country there is this huge variation. And so here you can see this variation in England that's supposed to have what from an American point of view would be presumed to be a standardized product, but they don't have a standardized product. So why might that be? So then we look at patient to nurse staffing in English hospitals in every other country, and we find a trajectory here that looks almost like that mortality curve I just showed you. So again, each one of these bars on this chart is a hospital, and it is their patient to nurse ratio or workload. So in England, which I'm presenting to you now, the average number of patients that nurses take care of in NHS hospitals in England is about 7.8 patients each. But it ranges from hospitals where nurses take care of only 5 patients to hospitals where nurses are taking care of almost 11 patients each. Okay, that is a huge variation, again, in a country that says they have a national system. So they have big mortality across their hospitals, and they have big differences in nurse-to-patient ratios, and you know where this story is going. It's this difference in nurse-to-patient ratios that is a very big factor in explaining why they have that big variation in mortality. Nurse-to-patient ratios is one of the most important single factors that explains variation in mortality across hospitals. We have exactly the same problem in the U.S. with very huge differences. Overall, nurses in the U.S. are taking care of about 5 patients each, but the variation, it goes from 3 to 12. We all don't have to have the same ratio because our systems are different. So it's not inherently true that the NHS hospitals are less safe than U.S. hospitals because their average is higher than our average, because we of our national policies, our length of stay, our level of technology, our capacity in the community, every country won't have the same ratio of patients to nurses. What is important is why within the same country, in the same fiscal climate, you would have this much variation. Well, clearly, the decision makers, and this is important to realize, the ratio of nurses to patients is not a given. Somebody is deciding this. I have heard since I've been here that, and Beth has been trying to explain this to me, that there is an expected ratio. Now, we haven't, I don't want to use exactly ratio because that implies other things. So an expected workload of nurses to patients that I think is on the order of 4, more or less, depending upon what you're looking at. But everybody's looking at me like there's a standard here. Well, we haven't done the study, but I'm willing to bet that you will have exactly the same variation in staffing that we find in 30 other countries, because what's different about Australia than all these other countries? Even in England, where they have a National Health Service, they have this variation. So that variation is explaining these differences in mortality. So very interestingly, we find in all these 30 countries the same relationship between nurse staffing and mortality. Again, these are countries all over the world. Some of them are rich, some of them are not too rich. They have different healthcare systems, different financing, and generically we find that every 1 patient increase in a nurse's workload is associated with a 7% increase in the odds of dying. We focus particularly on general surgery because almost all hospitals do general surgery. It's done in every country, so we picked something that we could compare across countries. So let me say this again, because it's a generic relationship we find in every country. Every 1 patient increase in a nurse's workload in a hospital is associated with a 7% increase in mortality from common surgical procedures. And we've, have looked at beyond general surgery, and the same pattern is there even if you look at higher mortality kinds of conditions or medicine as well. So we just published, I think, a landmark paper. If you haven't seen it, I would urge you to get it because I think it could be very useful to you. It's a paper, and as far as I know, it's the first paper ever published on nursing by nurse researchers in the Lancet, which got worldwide coverage from our European study and kind of opened up doors everywhere. So believe me, if you take a paper from the Lancet into any of your meetings, people will pay attention to it. So one of the things we do is we do studies that are too big to ignore, and we try to put them in the best scientific journals because, we are studying things that nurses already know the answers to, but other people don't know the answer. So we're not convincing ourselves, we're convincing others. So that Lancet paper, what it shows, again, is in Europe, across these 9 countries, every 1 patient added to a nurse's workload associated with 7% increase in mortality. Find the same thing in the U.S., just published a paper in South Korea. So we find the same thing everywhere. We also studied, does nurses' education make any difference on mortality? We've also done this research in the U.S., even in China, and recently in South Korea. We find that every 10% increase in the proportion of nurses in a hospital that has bachelor's qualifications is associated with a 7% decline in mortality. So the more bachelor's educated nurses you have, the lower the mortality. Now, this has been very impactful in Europe because we actually went to the European Parliament with the support of all these countries, and you might be surprised, I was, to learn that in the EU, they're attempting to standardize their qualifications for everyone in every occupation because the idea is that people should be able to move to different countries in the European Union, and patients should also be able to move around and get the same product of health care. So they've tried to standardize this. So all the other occupations are standardized at the bachelor's level at least, but probably no surprise to you, the requirement in the EU was only a 10th grade education plus vocational training. That was what's on the books until we did our study. I was kind of shocked at that because I thought, well, at least they have 12 years of high school followed by something, but 10 years. So our study showing that in Europe, the proportion of bachelors was highly associated with mortality, then led the European Union for the first time ever to recognize a bachelor's pathway for nurses in the European Union. Now, we didn't yet, we're still working on it, have quite enough clout to get rid of the bottom level requirement, so now they have 2 requirements. We couldn't get rid of it. By the way, you might be interested in this, those of you who follow this internationally. Germany has no bachelor's prepared nurses. Germany is very powerful in the European Union because everybody owes money to Germany. So we weren't successful in eliminating the lower level, but we were successful in getting recognition of a bachelor's pathway, and what that meant even in Germany is that Germany has to provide now access to bachelor's education to their nurses. And then ultimately Germany complied with setting over the next 10 years, they want 10% of their nurses to have baccalaureate degrees. Now that's pretty far off the European average, where a number of other countries like Australia have already gone to 100% baccalaureate nurses. In our study, both Norway and Spain have all baccalaureate nurses. But what we did was we took all these numbers and we estimate from our big study, big science in the Lancet, that if all the hospitals in the 9 countries we studied had at least 60% baccalaureate nurses at the bedside and workloads of no more than 6 patients each, that more than 3,500 deaths could be prevented every year in those 9 countries. It's a pretty big number, and that's why you got so much press on it. So, you know, we know that we save lives, but I think this research just helps everybody else realize this. Now, there are a number of policy initiatives that we're all trying in our countries to improve nurse staffing, and I don't know that anyone has the answer, but we borrowed actually an idea from Victoria. This is the exchange of ideas, and in California, which is one of our biggest states, we legislated nurse-to-patient ratios. And so far, that's the only state among our 50 that have adopted it, but we have studied it, and I'll tell you a little bit about it in a minute. We also have states that are trying a different strategy, which we're also in the process of studying in a comparative. We're looking at the comparative effectiveness of different strategies yielding better staffing. So there's really no transparency about what staffing is, whether you mandate it or not. Nobody knows what it is. Nurses don't know what it is when they go to a hospital to work, and patients don't know what it is when they go for care. So the theory is if we were more transparent about staffing, it would raise the level of staffing of the laggard institutions. And so we are trying in the U.S. mandatory reporting, public reporting of staffing to see if it will motivate, again, the hospitals that are lagging to come up at least to the average level. We've also prohibited mandatory overtime as a way to try to deal with the fatigue level among nurses that also complicates staffing. And then about half of our states have mandated a process to determine evidence-based staffing in a hospital. So in general, the process has to be a committee. Nurses have to be, and we're talking about clinical nurses, have to be a main part of the committee. The process has to use evidence to determine for that hospital, given the level of acuity of their patients, what safe staffing is. So trying to mandate a process is again going on, and we're studying all these things. So let me just tell you a little bit about what we found about California staffing ratios, since you are also, you know, actually this idea came from Australia. So California mandated ratios, and you can see that in a shadowed box down the side. And then I've compared the actual staffing complements in 3 other states that don't have ratios, Florida, New Jersey, and Pennsylvania. And what we can see is that California, across every clinical area, and they mandated by clinical area, and the California mandate has to be followed at all times. And there's been 100% compliance, because if they don't comply, they lose their license, and they don't get paid from our largest federal program. So it has big teeth in it. So they're all complying. So on average, nurses in California have two fewer patients in their workloads than nurses in my state. And it goes, right in med-surg in particular. Med-surg is one of our most difficult areas and where we have the most variation in staffing. But it's true that California has significantly better staffing in peds. ICUs are about the same, because we have a commonly accepted now staffing complement in ICUs that's a minimum of 2 patients per nurse, and pretty much all the hospitals practice that, so that didn't even need to be mandated in California. Can see that the mandate in psychiatry and acute psychiatry in general hospitals was not more than 6 patients per nurse, and you can see that the other states, Florida in particular, have almost 9 patients per nurse in psych. So California ratio was successful in putting out the most favorable nurse staffing in the U.S., and so we found that also their outcomes are better. They have the lowest risk-adjusted mortality compared to the other states. They solved their nurse shortage. They have a massive nurse shortage before they implemented ratios. And of course, the reason why implementing ratios has anything to do with the nurse shortage is that they couldn't attract or keep nurses, which is amazing, because California is a place where everybody might want to go and live. Nurses wouldn't come there or stay there because they didn't have enough nurses, and the burnout rates were very high and so forth. So mandating ratios not only improved the patient outcomes, but it improved the nurse outcomes as well. Importantly, we found that the safety net hospitals, which are our hospitals that take care of poor people who primarily are always lagging on nurse staffing, and one of the reasons why they have poor outcomes is they don't really invest enough in nursing, and that mandate made those, the public-private thing is a little bit different between our countries, so our whole system is private for the most part, and then we have a few public hospitals, and they tend to be the safety net hospitals that are underfinanced. Having the mandate, which was unfunded, none of the hospitals got any additional money. All the public hospitals, meaning the safety net hospitals, for the first time ever, came up to the standard of staffing for the rest of the state and vastly improved the outcomes of the people there. So in our sort of trying to use these data to drive policy in the rest of the country, we compared what the mortality reduction might be in states that didn't have the California ratios by taking the information that we had from California and their lower mortality. And so we estimated that in my state of Pennsylvania and the nearby state, New Jersey, that if we had California ratios, whether or not we mandated them, any way we could get to that complement that California has, we could reduce mortality after common surgery by 13%, which is thousands of lives each year. The clinical and human risks of readmissions is high. We already talked about this. We are very concerned in the U.S. because over 20% of our elderly patients with certain common conditions like heart failure going back into the hospital within 30 days, and it's costing literally billions of dollars. We were interested in knowing, what does nurse staffing in the hospital have to do with readmissions? Because in our setting, everybody's having these add-on programs of transitional care, care coordinators. They're adding all this on top of, and pretty much without looking at what inpatient nurse staffing is, because nobody thinks that inpatient nurses can really do much about readmissions. They don't think of nurses in that way. So we started looking at what's the relationship between inpatient patient to nurse ratios and readmissions, and it turns out that nurse staffing is one of the major predictors, inpatient nurse staffing, major predictors of readmissions. So we're now penalizing hospitals in the U.S. for excessive readmissions. We published a paper showing that hospitals with the best nurse staffing had a 25% lower odds of being penalized at all for excessive readmissions and a 41% lower odds of getting the maximum penalties, which are multiple million-dollar penalties. So then we're starting to build a business case for why staffing at a more reasonable level would be good for the hospital bottom line. This is also true in pediatrics. For those of you who are in pediatrics, each one patient increase in patient-to-nurse workloads in pediatric inpatient services is associated with a 11% increase in readmissions among children. So now we're starting to build a business case for what's the relationship between having adequate nurse staffing and a good bottom line for the hospital. So we're taking every single performance measure that our hospitals are now being paid on the basis of. We're either incentivizing them to have better patient satisfaction, or we're penalizing them if they have certain avoidable outcomes. Patient satisfaction is now 25% of the entire incentive payment. Nursing is more highly related to patient satisfaction of the hospital than anything else about the hospital, including medical care. Hospital-acquired infections, nurse staffing is very significantly related to hospital-acquired infections, with hospitals having less favorable nurse staffing, having much higher infections, poor glycemic control. Another big expensive item that sounds very medical, it turns out it's highly related to nurse staffing, falls. So we're building this business case, putting all these things together. And just a couple of examples. In our state, in Pennsylvania, hospitals with better nurse staffing and low nurse burnout had 30% fewer hospital-acquired infections. Then we figure out what is the average cost of a hospital-acquired infection, which we are no longer reimbursing hospitals for, so this is just a net loss to them if they have these infections. We estimated an annual savings to the hospitals just in our one state of $68 million a year. The same thing on trying to eliminate poor glycemic control, which is another never event that we don't pay for. These patients are very expensive. They're more likely to die. Having better nursing reduces poor glycemic control. And so we're putting all these things together in a number of different business cases. And by the way, I've given you some citations here. So can we put these up on your website? Okay. So if you want to go get the citations to use yourself, you can follow this and get them. Beth's going to make them available. So here in a big study, we put together all the results in the U.S. from all these different studies, and we estimate that the savings to the hospital on the reduction of expensive adverse outcomes that could be prevented totally pays for an increase in the nurse staffing. So there is no cost to the hospital in having the best staffing. As a matter of fact, it's costing hospitals a lot not to have appropriate staffing. So this is now, I think, what we all have to work on, building this case, because hospitals are looking at this big bill that comes from having all the nurses, and they don't either realize or take into account that this is not just a cost over here. It's really generating revenues because people come to your hospital because you have good nurses. And it's preventing these expensive complications. So it's really not costing hospitals, if they look at it in the total gestalt, not costing them anything to have more nurses. And in fact, it's costing them a lot not to have nurses. I want to just make a few little points. I'll go through some of these rapidly to give you a sense of what other kinds of things we're learning. Nurses everywhere are moving to longer and longer shifts, so we've seen, a transition, all of our countries, from 8-hour shifts to 12-hour shifts. We find that those are not without consequences for patients, that the longer the shifts, the higher the risk of errors and poor quality of care and poor patient satisfaction. And we've given you some citations if you want to look at it. Also, we've been looking at overtime, and overtime, whether it's voluntary or mandatory, is associated with higher risk of medical errors. So this starts raising the question about whether nurses' hours should be regulated in terms of the safety of the public, both in terms of overtime and an overall regulation of hours. As you know, there are many other occupations who are in high-risk occupations whose hours are regulated. I think maybe I heard something about you are having some regulation in well, air traffic, yes, but we heard some rumors that Australia was thinking about regulating the hours of nurses. So if this is anywhere, let me know, because I'd be interested. But this is becoming an issue in the U.S. because nurses are not voluntarily limiting their hours, and they're often working in a fatigued state, increasing the risk for patients, whether if nurses don't voluntarily take care of this issue, that regulation may come in. Just one note on foreign educated nurses. We think, many of our countries, that we can reach out and get nurses from other countries, and there won't be any consequences for the quality of care or the satisfaction of our patients. It's absolutely wrong. So now that we have all these different countries, we're looking at the proportion of their nurses that have been educated in another country. Doesn't matter what kind, I'm not picking on any one country. What we're saying is that nurses educated in any other country, practicing in your country, don't deliver the same product as your own nurses. And so we find actually higher mortality associated with a higher proportion of foreign educated nurses. We just finished a study in the UK showing that the more foreign educated nurses they have, even counting Australia as foreign to England, the higher the patient dissatisfaction. Nurses everywhere are saying that their environments are not appropriate, that they're in environments that are detracting from their performance levels. And here you can see across all these countries that for the most part, if you ask nurses what the quality of their work environment is, at least half of them, and sometimes up to 3/4 of them, say their environments are only fair or poor. I let you look into what we mean by a work environment, or I can answer it later. But work environments are tremendously important because we find in every country that we studied that hospitals with better work environments have substantially lower nurse burnout on the nurse workforce side, and then on the patient side, the patient safety in hospitals is highly associated with what nurses appraise to be the quality of the work environment. So in each one of these countries, as the work environment gets better, this line is going up, which means the rating of patient safety in the hospital is going up. So a direct relationship between poor work environments, high burnout, turnover among nurses, and patient safety for patients. Now, another reason why hospital work environments are very important is because they interact with staffing. So we found that if you spend a lot of money on staffing in a hospital with a poor work environment, you're wasting your money because it doesn't really have any impact on patients, because the work environment is so undermining the efficiency of those nurses, you're not getting any value for having additional nurses. But improving nurse staffing in hospitals that have good work environments has a huge impact on patient outcomes, which just brings me to Magnet. And Magnet is our evidence-based intervention to improve the work environments. When I talk to people in hospital management or policy makers, they think this idea of work environments is kind of a mushy idea, and they want to know, well, if we wanted to improve the work environments, what do we do first? Well, we have now literally 30 years of evidence that shows that the journey to Magnet that's now been operationalized in this Magnet recognition program that is international is an intervention. We've done it before and after studies. Any kind of hospital, big or small, teaching or non-teaching, in many different countries, if they take the blueprint that comes in the Magnet program for improving the work environment, that at the end they have a substantially better work environment, and better outcomes and better nurse work environments. And so it's great that you have the 3 magnet hospitals here. Hopefully we'll see more of a critical mass of magnet hospitals. It's important to say that as wonderful as I'm sure Princess Alexandra Hospital is and was, it's not an award for being good. It's an intervention. And so in the U.S. now, we're coming up on 10% of our hospitals having magnet. And it raises the bar of all the other hospitals, because every hospital in America now either has a magnet, has put their application in for a magnet, wants to be a magnet, and so it's having this impact of improving work environments throughout the country, which was its intention. Briefly, we know that magnet hospitals have better outcomes in every way. We just published a paper in JAMA showing that magnet hospitals have lower mortality for neonates. We've already published that they have lower mortality in general surgery. They have lower infection rates. They have better retention of nurses and lower burnout rates. And recently, and you might want to take a look at this, a great paper on the business case for magnet hospitals just published in the main interdisciplinary journal Medical Care that shows that the costs, and the costs are not insignificant, as Veronica will tell you. You have to make some costs in this process, which, by the way, this process is not top-down, it's a bottom-up process. Of all the reforms that have been foisted on nurses over the last several decades, this is a reform that staff nurses like to do, because it's exactly what they're about. So this is not something they moan and complain about. It's energizing for staff nurses. And what we find in the business case is that this initial investment that has to be made by the hospital starts to be paid back in the second and third year after magnet designation, because magnet hospitals have higher revenue than matched hospitals, because they have better outcomes, they attract more patients, they attract better doctors, they attract better nurses, and overall, their revenues are better. So you might be interested in taking a look at that. So just to end, if I had to say one thing about what I think all of our work adds up to, is that nursing is the foundation for quality and safety. And until we stabilize nursing at a reasonable level of staffing and create good and supportive work environments, that we're not going to succeed in reducing medical error, and we're not going to create the satisfaction that our public wants or the level of quality that we would all like to have. Thank you very much.
Thank you, Linda. Are you happy to take just a few questions before morning tea? We don't have a lot of time before morning tea, and I'm sure you're bursting with questions. So there are 3 microphones in the middle part of the auditorium. If you'd like to make your way there, we'll have some questions. I think you stunned them. There's no one moving.
It's like, I know, drinking out of a fire hose. I'm sorry, this is like 30 years of research. I want to make sure you know every little thing. And I didn't even really tell you about a lot of things. We could be here all day.
Linda is going to be with us all day today, so you may wish to approach her while she's trying to eat her morning tea and lunch to ask her some questions, and I'm sure she'll indulge you in that. Ladies and gentlemen, we'll break for morning tea now, if we can be back at 11 o'clock. Thank you. Just thank Linda again very much for her time.
Come back.